Now I'd like to introduce our first quick hit session. It's on genomic sequencing in heart disease. Very much looking forward to this talk, and I'd like to introduce the speaker, Dr. Stuart Cook. He's the director of Singapore's National Heart Institute, a professor of clinical and molecular cardiology at the Duke National University of Singapore Medical School, and a professor of clinical and molecular cardiology in Imperial College of London. And if you need any miles, he's the guy to talk to.
Thanks, great. Thanks very much. Great. Thanks very much. I'm afraid I'm about to science bomb your meeting, unapologetically actually, because I think genomic sequencing and genetics is really changing the world. It's changing it right now. It's going to change it more. And if it doesn't affect you in the audience today, it certainly will affect your children, and it's going to change how we manage our patients, diagnose and treat them. So, this is a kind of a genetics 101, and I'm going to summarize the whole of human genetics in a single slide. But just to remind you, if you've forgotten, there are two broad distinctions of types of human genetic disease. So these can be Mendelian traits, which are traits that run in families, in this case in an autosomal dominant way. So your children have a 50% chance of getting the disease that you have. They're usually single gene disorders. They're dominant or recessive, so either a 50% chance or 25% chance that your children will get the disease. But they can be multigenic diseases as well, like dilated cardiomyopathy, which I'm going to talk about today. It has multiple different genes that can run in the family in this way. The other form of human genetic disease is complex traits, which probably most of us in this audience suffer from one of these, unfortunately. And these are things such as obesity, hypertension, most forms of hyperlipidemia. And here the environmental effects are very, very strong. And multiple genes are involved. So in terms of determining how our waist-hip ratio, there are probably thousands of genes involved, all of very, very small effect. But obviously this is also strongly influenced by the number of burgers that you eat. So these are the two big breakdowns that we can make in human genetic disease. And I'm not going to talk about this area here with regard to genetics, because the genetic effects are very, very small. And there is a question about how actually useful they are in terms of looking at a diagnosis, treating a patient, or even actually stratifying a patient. So I'm going to leave this alone for today, and we can maybe discuss that offline. What I'm going to focus on today is Mendelian traits. So these are, if you have a mutation in that gene, there's a 50% or 25% chance that your kids are going to get the disease, and you are likely to get the disease yourself. So this is a few examples of where this is important. You'll probably recognize this chap from a few years ago, from Reggie Lewis from the Boston Celtics. This guy here was a good footballer in the UK, named Fabrice Muamba, and Angelina, who you probably heard about. Now, why are these people important? Well, Reggie died from hypertrophic cardiomyopathy when he was practicing off the court with some friends. His heart was too thick, and he either had obstructive disease or he had a ventricular arrhythmia. Fabrice Muamba, he amazingly had a cardiac arrest for 78 minutes, pumping on his chest, multiple shocks, and he came through that, and it is widely understood that he had an underlying genetic arrhythmia. And Angelina, she has BRCA mutations, and she's had a bilateral mastectomy to prevent her, she presumes to prevent her getting breast cancer so she can live a long and fruitful life. So all of these people, single gene disorders affecting if they die, if they nearly die, or if they're going for a preventive strategy, in this case quite a radical strategy of a bilateral mastectomy. But genetics can inform prevention, and I think this is something we need to think about for the future, because I think this is something we should be aiming for rather than just treating the end stage, which is disease. So genetic disease of the heart and circulation can cause sudden death and affect about 1 in 100 people. There's over 100,000 people in the States every year who die from a sudden death. Most of them are young, a lot of them are children. And so this is not uncommon that these Mendelian diseases, these single gene diseases, are actually causing a fair amount of mortality and morbidity in our populations, and often in young, productive people with young families. So why bother doing a genetic test? What I can do in the clinic, I can take a family history, I'm going to take a few blood tests and measure a few liver function, kidney function. I'm going to do an ECG, I'm going to do an echo, and then I'm going to do an MRI. I'm definitely going to do an MRI because that's what I do, so please refer lots of people for MRIs. So if this is what I do, then why do I also need to do a genetic test? What's the added value of doing a genetic test for the patient in front of me, either for the patient themselves or for their children? I want to give an example here, and this is not a cardiac heart failure. What I'm talking about here is cholesterol. So if you don't know, this is not a good cholesterol level to have, and if you have that, you should be treated. And here we have a thin person on the left as you look at the screen, and a slightly chubbier person on the right as you look at the screen. And if they're sitting in front of you in the clinic, and you would say, which of these guys is most likely to drop dead? Well, to illustrate the point here, I'm giving this chap here a gene defect, probably an LDL receptor, whereas this guy here loves burgers. Now, this is different because this person here has had his entire life, since the age of 6, to fill his whole body up with cholesterol plaques in his carotids and his coronary arteries, whereas this guy here has only been chomping burgers very big way for the last few years. So actually has less cholesterol. So in terms of those two people sitting in front of your clinic, if you look at the cholesterol alone, they look the same. But if you look at their genetics and you find that this patient here has a mutation in the LDL receptor, this is the chap who's going to die, and this is the chap whose children might die as well, and their children's children, because it gets passed down in that way. So this is the person you want to be checking if he has an LDL mutation. So why bother doing a genetic test? As I mentioned, you want to do a diagnosis, so this can confirm a disease or be used for predictive testing in family members. Prevention, new therapies for gene-positive individuals. I keep coming back to this because I think in some conditions like dilated cardiomyopathy, which is the commonest referral and reason for cardiac transplantation, which is a massive industry, costs a huge amount of money, it could be that if we get these people early, at least in proportion, we can stop them getting the disease. Prognosis, not all mutations are the same. I'm going to talk about that briefly. And a stratified treatment, as I just illustrated with the hypercholesterolemia case, you can't just treat the biochemistry. In some instances, you have to treat the gene, and that affects the patient and their family. So I'm going to talk about here how genetics matters in heart failure syndromes, and here I'm going to talk about dilated cardiomyopathy. There are other syndromes that I could discuss, but we don't have time. So I'm just going to show you a little movie here. Do we have a movie? Of what my day job is spent looking at things like this in a darkened room. And whereas we heard in the last talk about the holistic and knowing about the patient's number, the telephone number, I do know this guy's number, but it's his ejection fraction that I know, and his end diastolic volume and not much else, so apologies for that. But a point to make with this case here, and that's fine, you can go back to the next slide, is that this condition, even if you're going to give them diuretics, if you're going to give them ACE inhibitors, if you're going to give them beta blockers, if you're going to give them antifibrotic, if you're going to give them a device, it's a progressive condition, and they do end up going on towards heart transplantation. So I think we need to come upstream of that position you just saw there and try and prevent it. In terms of genetic causes of dilated cardiomyopathy, this was in 2011, so these are the commonest genes that we've previously tested, and these are the published proportion of patients who might have a mutation in those genes. And with the wind behind you on a good day, you might get to 25% of cases, which isn't very impressive. We published this paper with Cricket Seidman's group in the New England Journal in 2012, and in this paper, we sequenced this gene here, the titin gene, which is the biggest gene in the human body, which had previously escaped genetic interrogation because it's just too big. It's 100,000 base pairs long. But with the new sequencing technologies, we can sequence it. And we found that mutations in up to 25% of cases of DCM had a mutation in this gene. So this changes things quite a lot. So if you take all of what we knew before, you might get up to about 25, 20, 30% if you're lucky. But this up here is between 20 and 25% on top in a single gene. So this now makes genetic testing for dilated cardiomyopathy important because we can now pick this up commonly and then go and screen family members. We have a paper which is currently in Press at Science Translational Medicine, and I just want to make a point here. So what I'm showing here is the titin molecule, schematically shown here. As I said, it's a huge molecule. And what we now know is not just if you have a mutation in the gene, but where that mutation falls. If you have a mutation at this end of the gene, you'll get the disease, and you'll have a mildly impaired ejection fraction. If you have a mutation in the gene at this end of the carboxy terminus, you have severely impaired ejection fraction. And the difference between these two is about a 20% difference in ejection fraction, or 20 mils of indexed stroke volume. It's absolutely massive. And what about outcomes? So we have some preliminary data now, again in the paper which is currently in press. We know that if you have a titin truncation compared to those who don't have a titin truncation, you're more likely to die, need a cardiac transplant, or require an LVAD. And actually we have a hint that these patients are all more likely to have arrhythmic events like the lamin mutations, and it might be actually these patients need to be stratified for device therapy at an earlier stage to prevent arrhythmic death. I just want to put this out there. This is non-scientifically proven because it's observational retrospective, but this, I just want to make the point here that actually genetic DCM is potentially a reversible disease. This is a paper from Magda Yacoub done at the Harefield Hospital just outside of London a few years back, where they used LVAD as a recovery program, so when people recovered their function, they took the LVAD out. We now know from having sequenced these patients that a number of these patients in the recovery cohort actually had a titin truncation. So titin DCM is actually a recoverable disease with left ventricular unloading. And I think this opens the way now to think of new therapeutic approaches to look at these particular patient groups who respond well to left ventricular unloading, that you can reverse the disease and prevent these people going on to require cardiac transplantation, which is a very big deal. So what are we trying to do? We're trying to get better, cheaper, and faster and disseminated sequencing, so not in someone's ivory tower, just in an academic medical center, but getting it out so it can be used widely of all inherited cardiac condition genes. So we want to confirm diagnoses, we want to stratify our patients, and we want to discharge those patients who don't have a mutation, whose father does, to a long, happy, healthy life, and not follow them up every year for the rest of their life with investigations and unnecessary scans, which costs a lot of money. So I just want to mention in closing here about a panel that we've been developing in my group in the UK and also in my group in Singapore. So we've developed a gene capture assay for all inherited cardiovascular conditions genes in one workflow that works extremely quickly on a single machine. So if you're interested in familial hypercholesterolemia, Marfan, low SD syndrome, dilated cardiomyopathy, hypertrophic cardiomyopathy, ARVC, you name it, anything that is important in terms of inherited cardiac conditions is represented in this panel. And it's a seamless workflow, you can turn it around in 2 days. So just to mention, obviously at the moment with the regulatory landscape, we can't say this is clinical grade, so it's research, but we cover all, in each case, for instance, in dilated cardiomyopathy, we cover all the clinically important genes, and then we add in some research genes which are less commonly encountered as well. And this works better than Sanger sequencing, just to put that on the record. It's more comprehensive and it's more accurate. But we still, because of regulatory reasons, have to do Sanger sequencing and use this on a research basis. We also use this as a sudden death screen, so for molecular autopsy. So when people have died and the coroner cannot find a cause or the body has decomposed, we will screen the DNA from these individuals using this panel. And we're doing this in Singapore now, and we're picking up lots of LDL receptor mutations, undiagnosed hypertrophic cardiomyopathy, Fabry's disease. And this matters then, it's closure for the family, but it also means that that information goes back to the family and it prevents their family members dying. This has been commercialized by Illumina. It has been said that knowledge without application is wasted knowledge, so we are trying to apply this in the clinic, and this will be available next year through Illumina for anyone to buy off the shelf. I don't make any money, I wish I did, but it's there for people to use, and it's a standard panel that really gives unprecedented coverage, and I think will really transform what we're doing in our clinics, particularly if everyone's using the same test, because then we can compare between labs, which we currently can't do. So you may have heard about whole exome sequencing and whole genome sequencing, and what people quite often say to me is, oh, that's all very interesting, but why don't you just do a whole exome panel, i.e. just take something off the shelf and screen all the genes in the genome and then just look at the ones you're interested in? Well, this is why not. So this is an average of 80 people done on whole exome sequencing, running to the standardized guidelines that we do, and I'm going to give a hint here that red is bad and green is good. And what we're using, anything which is red is below a 97% cutoff. So basically with our panel, which is cheaper, quicker, and faster, pretty much all the genes are in green, whereas using whole exome sequencing at the given guidelines is far more expensive and basically not callable. So you just can't use it because you miss bits. It hasn't been optimized for this use, it costs more money, and it doesn't work. So that's why. So the new assay is affordable, fast, and comprehensive. So currently, if you want to screen a gene, this is US dollars, it costs you about $500 per gene or thereabouts on consumables for Sanger sequencing. So That's what it costs now in the new assay. So we'll be charging, well, Illumina will be charging $1 a gene. Okay, and so the panel is comprehensive, so it's 174 genes, so that's $174, and you've done all your capturing and all your sequencing, and you can turn it around within a couple of days. So this is going to change what we do. It may not change it today, but it will change it tomorrow. So I just wanted to mention that about 4 people in this room will have a radical titin mutation. I don't know who you are. Maybe you do. And in 2 of those people, that's actually going to be important for your heart function. And this kind of interpreting this kind of data as we go forward is going to be very important as we all move, and our children certainly move, towards getting their gene sequenced, either whole genome or whole exome. We're hoping that by doing the sequencing in our patients and in our controls, we can inform our decisions as to what to do with those mutations with those of you in this room who have them. I come from here. It's a lot warmer than it is here. Thank you very much.
I'd like to just, we have a few minutes. Anybody have any questions for Dr. Cook? Yes.
My name's Steve Gould. That was a terrific talk in a short period of time. I have a complicated question I'd like you to sort of philosophize on.
Sure.
I think the science path is clear. You laid out a very compelling rationale for diagnosis, prevention, and question mark, et cetera, et cetera. I'd like you to think about the overlap of the science. We live in a world of evidence-based medicine, healthcare reform, healthcare economics, and I'd like you to overlap all of those. What is the level of rigor that will be required in terms of sample size and studies to provide compelling data to change practices and to support reimbursement? However you want to answer that, because you touched on all of those, some of the economic numbers you gave, so it's a little unfocused, but
yeah.
try and wrap those in.
Yeah, well, thank you for that complicated question. But it's important to ask it, because I think if we really do want to transition this into mainstream healthcare, then we need to address all of those things. In terms of reimbursement, some of these tests are actually already reimbursed for cardiomyopathies and also for familial hypercholesterolemia screening. What do we need to do to move it forward? I think what we need is a big collaborative basis working with big cohorts, all of whom are genotyped. I think people going into heart failure trials, particularly those with dilated cardiomyopathy, should all undergo testing such as this. And then with enough numbers and enough power and enough collaboration, we're going to see genotype-specific effects in outcomes. For instance, you might even see in a general heart failure trial that those who have mutations in KCNQ1 and the other long QT syndrome genes actually are more likely to have arrhythmic events. But the only way to do it is to sequence lots of people who are well phenotyped with outcomes. So we need to move it away from the basic science labs and the small scale. We need to move it into upstream in clinical trials, and those people running clinical trials should think about using this kind of panel. They currently use GWAS, which will pick up small effects, but this will pick up large effects. So if a person has a mutation in KCNQ1, they may actually require device therapy versus someone who doesn't. So big numbers, collaboration, using this as much as possible in well-phenotyped cohorts, and also they're getting control data, which is largely available now through other cohorts and through the Broad Institute actually as well. So phenotyping is key. Phenotyping and outcomes. There's no point in just measuring this and then just forgetting about the patient or what happens to them. So we need to know their phenotype, be convinced of their diet. I mean, dilated cardiomyopathy, I mean, how many patients do I get referred with DCM who actually have ischemic heart disease and in an unrecognized infarct by echo? It's very common. So phenotyping is key, big numbers and outcomes.
I've got a question. This is Fred Yurtz, I'm with Biotronic. And I have a question regarding kind of this new area of genetics called epigenetics and these nasty methyl groups that you're probably very familiar with. And I guess my question to you is there a relationship at all in this kind of early infancy of this area between these methyl groups and heart failure?
Okay, so epigenetics is whereas genetics has been around since Mendel and the P days, epigenetics has really, well, it's been around for a while, but not quite that long. And I think it's an extremely interesting area. It's also extremely complex. And the effects that, sizes that you see are very, very rarely, if very uncommonly, like what we see in the Mendelian genetic diseases. So it may be important in modification of risk, it may have some effect, but I think my personal standpoint right now is we can apply this now for clinical care. It's ready to go into the clinic. For the methylation effect, it's still in the back end, more in the science end of the studies, which we are doing, but we don't really know quite what to do with it yet. And again, the effect sizes are small. So it's interesting, but yet it requires time to go, would be my opinion.
Thank you. Don Lloyd-Jones, Northwestern. Thanks so much. Really, really great talk in a very complex area. And I'm going to ask a question that's going to make my sister really happy, because my sister's a genetic counselor. And I am a practicing clinician. And she makes the point when we get together every Christmas and every time in between, you know, I know nothing about how to counsel a patient about a genetic test result. And in fact, that counseling has to happen before I send the test, because the patient must be prepared for every possible outcome of that test. So if I know nothing about that, the patient knows far, far less about how to do that and how to receive this information. I think this is incredibly powerful stuff, but knowledge without empowerment of the patient and the clinician is actually just fear. So how do we change that paradigm to take this really powerful knowledge and make it truly clinically useful in ways that patients and clinicians can understand, and again, do that actually before they send the blood test, because that's when it has to happen.
Yeah, so I think many interesting points there, and I would just turn one of them around to start with. Are you a practicing clinician?
Yes.
So do you consent the patient before you listen to their chest?
I do.
You do not. Do you consent them before you do? You ask if you can, but you don't consent them. Do you consent them before you do an ECG?
No.
Right. So this is the dichotomy that we have with genetics, because when you mention genetics, everyone's like, oh, genetics. And you've got to do all this stuff. And I'm good with that, and I think we do have to counsel patients. Yes, but you don't tell them that if you pick up a hypertrophic cardiomyopathy strain ECG, that affects them, their insurance, and their family. And actually, that's probably more important than the genetic test, because the genetic test will, excuse me, will tell you risk, but those genes are not fully penetrant, which means that if you have the mutation, you may not get the disease, and the expressivity, which is how bad you get the disease, is also variable as well. So actually the test that you do is more important, and you don't consent the patient. So I think we've got this, and it's not just you. It's not just you. It's me too. But it's true for echo, it's true for MRI. So I think we've got we say an English phrase, our knickers in a twist about the genetics, because we do actually know how to interpret it pretty much. We can put probabilistic risks on what it means, but we get hammered with this consent issue, and we have to do it, and I completely think it's the right thing to do. But we have this kind of other life as a clinician where we don't do that. The same is true for incidental findings. So incidental findings, if you do whole exome, oh my gosh, what do you do if you find a BRCA mutation? When you do your full medical exam, do you consent them to feel their abdomen? And what happens if you find they've got a big spleen? You don't. So we're just, I don't know how we work it out, but I think it's an interesting area.
The difference is we're in one setting, and typically most things we're doing in the clinical setting is diagnosis. And what we're talking about here is potential prognosis. And they are different things.
We could argue on that.
All right, thank you, Dr. Cook. Very good.